Hello, my name's Nick Turner from the Royal Marsden Hospital. Welcome to webcast 8 from the San Antonio Breast Cancer Symposium, Key Randomised Trials 2. I'm here with Rob Stein and Carlo Palmieri. We've got 4 studies we're going to discuss in this website, the first of which is the first study that looked at a randomization in first-line endocrine-sensitive breast cancer between fulvestrant and anastrozole.
So this is the first study. It's a randomized phase 2 comparing anastrozole and fulvestrant at the 500 milligram monthly dose, 1-to-1, an open-label study in ER-positive postmenopausal patients with advanced breast cancer. And it aimed to recruit 200 patients. The primary endpoint was progression-free survival, and the particular presentation today was about the overall survival within that study. So the background to the study is that there have been 2 previous studies comparing fulvestrant at the 250 milligram monthly dose first line with anastrozole and with tamoxifen. And the bottom line is that in both of these studies, fulvestrant was equivalent to anastrozole and to tamoxifen. The confirmed study randomized patients between the 500 milligram monthly dose and the 250 milligram dose. And this showed a significant superiority for the 500 milligram dose. So it was both more effective at prolonging progression-free survival, and there was an overall survival benefit. So this study now seeks to look at the 500 milligram dose compared with the anastrozole in the first-line setting. The progression-free survival and clinical benefit ratio rates from the study have previously been presented and show that fulvestrant is significantly superior to anastrozole. So the clinical benefit rate was 75% with fulvestrant compared to 67% with anastrozole, with an odds ratio of 1.3, although it doesn't cross the formal statistical significance boundaries. Time to progression in the study, however, was significantly superior for patients treated with fulvestrant. The overall survival data we heard for the first time today. This wasn't defined as an endpoint in the original protocol, but the protocol was amended in February 2011. And the analysis was planned for at least 65% maturity, which means that 133 out of the 205 patients had died. The median follow-up was 49.5 months for fulvestrant and 42.5 months for anastrozole. And the analysis was conducted after 137 deaths. So the overall survival data we've seen for the first time today, and that showed that the median overall survival for patients who were treated with fulvestrant was 54.1 months, compared with 48.4 months for patients who were treated with anastrozole, which is a statistically significant prolongation in overall survival. The safety essentially was as has previously been described for both of these agents, with no new safety signals. So in conclusion, fulvestrant results in a statistically significant prolongation in both progression-free survival and overall survival at the 500 milligram dose, and is therefore superior to anastrozole. This was, of course, an open-label randomized phase 2 trial. The Falcon trial is a double-blind randomized phase 3 trial, which has now completed accrual. and we'll hopefully report round about this time next year or in early 2016, and we'll hopefully confirm the data that we've seen today that's showing that fulvestrant is the most effective of the endocrine agents to treat breast cancer.
Thank you, Rob. So Carlo, we've got two studies now that have compared fulvestrant 500 with a comparator, the confirm and first, both of which show an overall survival benefit, although in neither of the studies was it the primary endpoint. Do you want to tell us what your thoughts are about first and what it might mean for clinical practice?
So, I mean, firstly, I think it's a very interesting study. It appears to signal that we may be on the crest of a change in our practice, but it's a phase 2 study. We should bear that in mind. Falcon has been designed to test the phase 2 data. We should also bear in mind that 70% of patients were naive to any endocrine therapy. Only 30% had a prior endocrine therapy. So whether that influenced results, we're dealing with a very endocrine-sensitive population. At the moment, I think it shows us that potentially giving upfront SERD is potentially the thing to do for our patients. However, I think we need to wait the Falcon study before we can definitively say that actually OS is improved. If that is the case, then I think we probably do have a practice changing.
Yeah, so I guess the point there is whether this is a trial of sequence or whether it's a trial that tells us fulvestrant 500 is active. Because what we don't know is the proportion of patients in the anastrozole arm who went on to get fulvestrant at 500. So Rob, do you think this is an important issue with where we think about fulvestrant in a patient's treatment, where we fit it in amongst the other options?
I think the fact that there's a progression-free survival benefit, which is of course not contaminated by crossover, unlike overall survival, does say that fulvestrant is the superior drug in this trial. And it's also consistent with the data from confirm. And I think John Robertson looked in great detail at what had happened in the control arm of the other endocrine studies conducted in a similar setting, comparing anastrozole or aromatase inhibitors with tamoxifen, and made the point that the way in which patients behaved treated with anastrozole in this study was very comparable. And I think all of that points to the fact that this is actually a real result. And if Falcon does result in confirmation of this data, I think it will change practice, although of course it will have significant financial implications.
Sure, so I think that, Rob, that's a really interesting point. So for those of us in England at least, fulvestrant used to be on the CDF and we used to be able to access fulvestrant widely. But now fulvestrant is in the baseline budget, but without it necessarily being reimbursed in the baseline budget. Carlo, how does that affect you for prescribing fulvestrant where you are, and what do you think that means for treatment in the UK?
So, I mean, we can use it. We don't have an issue. It's reimbursed. We can use it in Liverpool. There's not an issue. But that will, as you quite rightly say, may vary, though it's factored into the baseline budget. We now have to remember that actually within the UK we have two devolved nations, Wales and Scotland. They set their own health budgets. They have their own drug list, and we know that in both those countries, I think they have limited access to fulvestrant, if any.
What about Northern Ireland?
And Northern Ireland, yes, sorry, Northern Ireland. I'm being corrected correctly. But I think that's right. I mean, and remember, this is a relatively simple drug to give. It's not toxic. It may improve quality of life. There's no data on quality of life. That would be interesting to see from this study. I think it's a challenge. I think if fulvestrant is non-accessible, I think it's a major issue, and I think we potentially may be doing our patients a disservice. And this is compared to what the other drugs we use, is relatively cheap compared to some of the TKIs we use, chemotherapy, chair time, etc., etc. So I do think it's another drug that is going to pose budgetary challenges.
Yeah. Well, Rob, what's your experience of how widely fulvestrant is accessible?
Well, I had access to fulvestrant very freely from about 2000. when it first became available through compassionate use program up to the time it came off the CDF. But in the last 2 years, it's been almost impossible to prescribe.
Really?
In either of the two hospitals I work in, yes.
And that's very interesting that actually, I mean, some places it just is available. In Liverpool, it's not a problem. And then a centre of excellence as well in London, you're having issues.
But it's a postcode issue.
Yeah, no, I agree.
And it comes down to how individual hospitals manage their budgets.
Absolutely.
And how they prioritise them.
And I think it's an increasing issue as drugs will come off the CDF in the future and potentially go into the baseline budget without them necessarily being reimbursed within the baseline budget. And it's a challenge that I think we will face increasingly in the future on how we manage patients. So increasingly, fulvestrant is being used now as a backbone therapy for trials to add on new targeted therapies. And Rob is going to tell us about some of the results of one of these phase 2 studies that was shown today.
So yes, so this is a rather different study. So the background is that fulvestrant is generally considered to work by promoting the degradation of the estrogen receptor in the nucleus. So it's often called a SERD, a selective estrogen receptor downregulator. But it also promotes the accumulation of insoluble estrogen receptor aggregates in the cytoplasm, possibly secondary to that action, which are cleared by the proteasome. And it's been argued, and there's some evidence, that these protein aggregates can be toxic and actually add to the anti-cancer activity of fulvestrant. And so this was a randomized phase 2 trial with the proteasome inhibitor bortezomib, which of course is widely used in the treatment of hematological malignancies, but not in solid tumors, in combination with fulvestrant. So the primary endpoint of the study was progression-free survival with secondary outcome measures of clinical benefit rate, overall survival and toxicity. And so the patient population were patients with estrogen receptor positive metastatic breast cancer resistant to an AI, so they were clearly postmenopausal. And they were randomized to either fulvestrant at the standard 500 milligram monthly dose or fulvestrant and bortezomib at the kind of dose that's used to treat hematological malignancies. It's quite a small study, so there were 118 patients involved. Patients were allowed to cross over from fulvestrant to fulvestrant and bortezomib on progression. And patients were monitored, or response was assessed on a monthly basis, so which is quite frequent. And the results show a numerical benefit for prolongation of progression-free survival with a hazard ratio of 0.73, but this did not reach statistical significance, even allowing for the rather relaxed statistics of a randomized phase 2 study. However, when you do a simple numerical counting procedure and look at the number of patients who were progression-free at either 6 or at 12 months, then there was a significant benefit for the combination. And so this raises the possibility of a new approach to endocrine therapy, but I think it's probably one that would only work in combination with fulvestrant, because the estrogen receptor aggregates have not, to my knowledge, been described with other anti-estrogen agents. But it provides a proof of principle that this is an approach that should be further explored. The toxicities, or the excess toxicity associated with bortezomib was low-grade nausea, diarrhea, and sensory neuropathy. This is all very well described toxicities of bortezomib, and were on the whole not severe. So it's clearly something that I think is worthy of further exploration.
So thanks, Rob. So this was a relatively small study.
Yes.
And I think one of the key points I would raise on a technical point is it was open label with crossover on progression. And small studies that are open label and then allow a woman to access the targeted therapy on progression, one always has to treat very cautiously in how one interprets them. But what was interesting in this study is some of the women who crossed over onto bortezomib actually stayed on the drug for a long time. So I don't know, Carlo, what do you make of this study? It's obviously a relatively small phase 2.
Yeah, I think the point you make just now, Nick, I think is the more interesting point from this study. Clearly, it was a relatively small study. It was I take it as a sort of proof of concept that you can get the drug in, that gives us a hint of activity, although it didn't meet its primary endpoint. But the women who crossed over from the fulvestrant and then got the bortezomib, I think that's the interesting group. Is that the way to use this drug, to use fulvestrant and then add it in if you get resistance? That, I think, was one of the key messages from this study. I mean, the second is actually that it needs a larger study, a randomised, a double-blind study, and potentially thinking about actually should the randomisation be to a sequence of where you pre-specify the switch, add in the bortezomib on progression. I mean, I think that's the key message I think I got from this study.
So Rob, there's lots of registration studies, in fact, already been recruited on fulvestrant. Do you want to tell us about any of those? Because I think one of the issues for a study like this is that there'll be drugs licensed with fulvestrant at some point in the future. Do you want to tell us a little bit about what those studies are?
Well, there are quite a number of novel agents being given in combination with fulvestrant. Novartis have a registration study for buparlisib, which is a pan PI3 kinase inhibitor, which we should know the result of next year.
Yeah, and as you say, Rob, and then there was also the study that's been done with the CDK4/6 inhibitor, palbociclib, and I think one of the questions will be where you fit targeted therapies with endocrine therapy in the future.
Well, I think it's a very interesting question, but it's how do you sequence therapies, and it requires quite a lot of work to do that. And I'm not sure we're going to achieve that because of the practical difficulties of doing those studies.
Sure.
So the next study we're looking at is a randomised multi-centre phase 2 neoadjuvant trial of lopatinib plus trastuzumab with endocrine therapy and without chemotherapy for 12 versus 24 weeks in patients with HER2 positive breast cancer. So the background to the study is that in animals, combination of HER2 therapy leads to complete tumour regression in animal models, and these results have been translated into humans with clearly meaningful responses in the adjuvant setting over 12 weeks from the group at Baylor. The purpose of this phase 2 was asking the question, if you gave treatment for longer, do you increase the path CR rate in these patients where you do not use chemotherapy? So the primary outcome measure in this study was there was a path CR rate as defined by no tumour in the breast or in the lymph nodes. And let's remember that where a non-chemotherapy doublet of HER2-directed therapy has been used in the Neosphere study, that's where they used pertuzumab plus trastuzumab, the PCR rate was 11%. So just to remind people, because this study used endocrine therapy in the ER-positive group, that there's crosstalk between HER2 and ER, so clearly probably want to be blocking both pathways if you're ER-positive and HER2-positive to stop potential resistant mechanisms kicking in involving ER. So this is the trial schema. It basically did a 1-to-2 randomization, took patients who were HER2 positive, randomized them to either 12 weeks or 24 weeks of lopatinib and trastuzumab. In those who were ER positive, they got estrogen deprivation with on-treatment biopsies for translational work. So these are the top line results. So the path CR rate of the 12 versus 24 week groups. So overall, the path CR rate was 12% versus 28%. In the ER positive group, the path CR was increased from 9% to 33%, almost a threefold increase, over a threefold increase. And in the ER negatives, the PathCR rate was stable at 20% versus 18%. So the main conclusion from this study was, what we haven't shown here was the stats for the study, but they were aiming for a PathCR rate of 45%. That was the primary endpoint to make the study significant. This clearly wasn't met. They got a lower than expected increase in PathCR. But this is the first study to show that you do get a meaningful increase in PathCR in the ER-positive group when you give it for longer with endocrine-sensitive HER2 doublet treatment. They've got ongoing molecular studies, but this again offers the tantalising prospect of potentially using a non-chemotherapy regimen to treat HER2-positive, ER-positive breast cancer. So the question this study poses, and what we need to pose ourselves, is can we legitimately avoid chemotherapy in some groups of patients who are ER-positive and HER2-positive? So the next study is a phase 3 randomised, double-blind, placebo-controlled, multi-centre trial of daily everolimus plus weekly trastuzumab and paclitaxel as first-line therapy in HER2-positive advanced breast cancer, Bolero-2 or Trio 019, a bit of a mouthful. So, as we know, resistance to trastuzumab is a problem in HER2-positive breast cancer. Women still, despite the introduction of trastuzumab, relapse and succumb to their disease. We know that the PI3 kinase pathway, the PI3 kinase AKT-mTOR pathway, can lead to resistance in HER2-directed therapy. We've now got agents which target this pathway, one of them being everolimus, an mTOR inhibitor, which has shown activity in HER2-positive advanced breast cancer in both preclinical and clinical studies. We know from previous phase 1-2 studies that everolimus plus trastuzumab and paclitaxel gives an objective response rate around 21%, with a clinical benefit rate of 36% in heavily pretreated HER2-positive breast cancers that have progressed on trastuzumab and taxanes. We know from Bolero-3, which was a study of everolimus plus trastuzumab and viloravine, that there was an increase in PFS in the trastuzumab-resistant patients in this study. It was statistically significant, although was it clinically relevant was the question from that study, but clearly showed the concept of blocking mTOR pathway. You could increase the benefit from the background chemotherapy with trastuzumab. So this is the study design. It involved 719 women. They were randomised in a 2-to-1 fashion to either everolimus and weekly Taxol and trastuzumab, or placebo and the same treatment regimen of weekly Taxol and trastuzumab. The primary endpoint was PFS as defined locally by investigators, and also looked at overall survival and the hormone receptor subpopulations. So these are the results. This is the PFS in the full population, and basically showed that there wasn't, based on the statistical design of the study, an increase in the progression-free survival for the whole population. So the primary objectives of the study was not met. However, they planned to look in the subpopulations, and when they looked in the HER2-negative subpopulation, remember the reason for doing this was that in Bolero-3, they saw a stronger signal in the HER2-negative population within that study. So they planned into the study to specifically look in the the hormone receptor negative subpopulation. And here they saw a significant increase in the PFS from 13 months with placebo to 20 months with everolimus. However, given the way they designed this study, actually it didn't cross their pre-specified threshold. It was actually 0.0044. The value they got was 4.9. So it was based on their statistical design, it didn't quite reach its significance, although numerically there's clearly an improvement, and the Kaplan-Meier curves show that as well. So one of the interesting things of this study was they looked at the safety profile. In particular, they looked at the fatal events. And what this study shows is the on-study deaths and the causes of on-study deaths. So the number of deaths in total was similar, 37% in the everolimus arm and 35% in the placebo arm. Below that are the reasons for death, and you can see that in the everolimus arm, the deaths due to disease progression was 1% of the overall population. The deaths due to adverse events was 3.6. So more patients were succumbing to adverse events than to disease progression. with placebo, all the deaths were due to disease progression. You can see below that the documented reasons, or the AEs that were documented as the reason for death, as being predominantly pulmonary or cardiorespiratory. So clearly there's a signal here that potentially safety, or how this drug was given in clinics or how it's handled, may be an issue, maybe reflective of where the drug was used in clinics where maybe they hadn't used it before. So obviously this is an indication of of some concern. So the overall conclusions from Bolero-1 are that it validates the preliminary observations from Bolero-3 that there's a treatment effect of everolimus based on HER2 expression, i.e. those that are HER2 negative appear to get a benefit that's not seen in HER2 positives, although it didn't meet the very rigorous pre-specified p-value. That given the results of Bolero-3 and Bolero-1, ongoing studies are evaluating blockading the PI3 kinase mTOR pathway, both with endocrine therapy and HER2 targeted agents in the studies listed below.
Okay. Thank you, Carlo, for your presentation. I'm afraid we've lost Nick, who had a prior engagement, but I had a couple of questions. So the Bolero-1 study, the toxicity of everolimus is really quite worrying, and I wonder what your personal experience with the drug had been.
Well, I think toxicities are an issue, and as often happens when a new drug enters clinical practice, some centres had had use of it within the clinical study, so probably aware of the toxicity and potentially how to manage them as per trial protocol, because often trial protocols often mandate how to manage these toxicities. Other centres have not had experience, so maybe more surprised by some of the toxicities, although normally they're published in papers, so you should be aware of them. I mean, we've found that the main problems of mucositis can cause an issue. Colleagues have had patients developing pulmonary problems that have necessitated disruption or stopping. So the toxicity sort of published from previous manuscripts is what we're seeing in the clinics. The one that I think a particularly problematic one is mucositis. So often you have to stop and then dose reduce. The more worrying one is the sort of pulmonary problems, which I think worries us. I think people on it are clearly, you want to keep an eye out for any lung problems, any issues that may be related to the pulmonary issues. And clearly with the adjuvant studies about to open in the UK, UNIRAD, which has a very strong safety component built into it with close monitoring of the patients, I think we need to be aware of it and stopping the drug when it appears. But the issue is, why was it so prominent in the study? It's not clear where the toxicities were happening or the deaths on the study. Were they in the countries which have never used it? Was it just one of those things with the drugs? I mean, it's been nice to know more about the patients who got it. Are there any predictive risk factors to predicting who gets it? Were the patients smokers? Did they have other comorbidities, lung disease, etc., etc.? So I think we need to know more about the patients who had the complications with regard to sort of pulmonary respiratory problems and more detail around them, because there may be, we need to understand who gets this toxicity, or is it completely idiosyncratic and it's not predictable?
I mean, my personal experience of everolimus is that I don't think I have really learnt how to manage the toxicities of this drug very well at all. And I think there was a remark made at some point in the presentation that after a number of the deaths, they produced guidelines on how to manage the pulmonary toxicity, and they only had one death subsequent to that.
So, I mean, that's, as you say, that, as discussed, probably indicates that maybe in centres not previously using it. I mean, the other thing is actually when the study was set up, how aware were they of the pulmonary toxicity? So how well the protocol reflect that? I think we, as always, need to be mindful of drug toxicity with new drugs. We're always, I think it's always sometimes a learning curve, and actually, we're increasingly running into these problems with these new targeted agents.
Especially if we don't actually use them a great deal.
Quite, yes, absolutely. So that's the other issue. And this is why I think actually being involved in clinical trials is quite important, because you get a handle for the agents, potential side effects, and then how to handle them. And I think, education is key, but that often only comes with experience of using an agent. and often sometimes the toxicities appear on study. The cardiac toxicity when trastuzumab was originally used were not expected. That cardiac toxicity in the original Slayman paper was not expected. So often toxicities appear that are not predicted from either preclinical or phase 1 studies. So one always needs to be aware of any odd toxicities in patients on targeted agents that may not have been previously reported. We do need to be always open-minded when we see patients with unusual problems.
So going back to the neoadjuvant study, what I found extremely striking in that is that there was an ongoing response in patients with hormone receptor positive disease who were treated for more than 12 weeks, which was just not seen in the hormone receptor negative patients. And it seems to me that hormone receptor positive, HER2 positive breast cancer is a different entity from hormone receptor negative HER2 positive breast cancer.
Yeah, I mean, I agree. I mean, the study used trastuzumab and lapatinib with targeted therapies. They used endocrine therapy, which is targeted therapy, one of the oldest targeted therapies we use in the clinic. But the ER negative just got the targeted therapy together. So I think what it indicates is that clearly if you're using hormone therapy with targeted HER2 therapy for long periods of time, you can increase the path CR rate. The question is actually if they went out longer, would they do better? That's an interesting thing. We know that when you give studies of giving AIs for up to a year, you progressively get better, you get more patients responding, et cetera, et cetera. With the HER2 negatives, they didn't give chemotherapy. That probably indicates actually these treatments need chemotherapy with the HER2 therapy. That
yes.
HER2 therapy alone is not good enough for these, very highly proliferative tumours. That just targeting HER2 is not enough. And we know from the original data with trastuzumab that actually single agent trastuzumab is a poor treatment. It only gives 10-20% response rates.
Yes. And there's a significant disease stabilisation.
Exactly.
Very low objective response rate.
So the interesting thing would have been, had they used chemotherapy in the ER negatives, what would have happened to the response rate? I think it would have been much higher, and we know that from the Neosphere study, they had an interesting path CR rate, but it was much less than the chemotherapy. So I think the take-home message from the neoadjuvant study is that endocrine therapy with targeted agents is a good thing, that actually you can, the longer you give treatments, the better. With the ER negatives, clearly you need chemotherapy with directed therapy to maximise the benefits. And I think that study from Baylor merely supports the Neosphere data, I think.
Well, it's goodbye from San Antonio 2014. We've all had a lot of fun being here and giving you some feedback from the meetings, so I hope you've all enjoyed it. A few thanks. The team at WG have been brilliant, particularly Phil, James, Joe and Chris, who are with me here, who've been endlessly patient, and the work behind the scenes is phenomenal. And also thanks to Roche, who have given an unrestricted educational grant to help us do this meeting. We hope to be back with you next year.